All right. Very good evening, everyone. Welcome to ISC Masterclass. This is the 11th edition of ISC Masterclass. We had a wonderful lecture last week by Dr. Raju Sharma on how do you assess or how do you image a liver SOL. And all of you will agree that this was a remarkable lecture by Dr. Raju Sharma. We received a lot of feedback and a lot of questions. And we thank again Dr. Raju Sharma for a wonderful talk. Same in this series, taking liver SL further, we have one other talk today that is how do you manage hepatocellular carcinoma? And this is a common issue, and all of us deal in our practice day to day. And for this, we have a great speaker. His name is Dr. Anil Arora. He is very popular. He is a head of department of gastroenterology at Sir Gangaram Hospital in New Delhi. He has a wide number of publications, and his knowledge is remarkable. Very humble, very good to talk to, and very methodical. We are going to have a treat listening to him today on hepatocellular carcinoma. In addition, we have two moderators today. We have Dr. Krishna Das, who is from Government Medical College Trivandrum, and we have Dr. Ajay Jain. He's head of department of gastroenterology at the Chaitram Hospital in Indore. So welcome, Dr. Arora. Welcome, Dr. Krishna Das. Welcome, Dr. Jain. We look forward to listen to you. And now I hand over to Dr. Saraswat to welcome you formally and take the lecture forward. Dr. Saraswat, please.
Thank you, Dr. Govind. Good evening, ladies and gentlemen. Once again, it's a great pleasure to have all of you attend and participate in the ongoing ISG Masterclass series, which, as Dr. Govind has told you, is finding continued popularity amongst all the residents and the gastroenterologist, hepatologist community in the country. As has been discussed on previous occasions, we do have participation and audience tuning in from our neighboring countries, distant countries from Africa as well as South Asia, and good feedback from all of them. As Govind has mentioned, the speaker for this evening is Professor Anil Arora. Anil Arora is a well-known speaker. I think he organized one of the most popular annual meetings, which has probably been running now for almost 15 years, if I'm not wrong. The annual Gangaram meeting, to which many of us have participated, and which is popular with the audience as well as with the speakers. He is a prolific author, as well as a popular speaker. And other than that, I have been knowing and I've been interacting with him for almost 35 years. When I was leaving the Department of Gastroenterology after finishing my DM at the All India Institute, Anil was walking in. Probably he might well have occupied the seat that I vacated in the department when he joined the department. And as a past president of the NASL, he's also been very active in academics, as well as now a member of the governing council of the Indian Society of Gastroenterology. With these few words, I would request Professor Arora to begin his lecture for the evening on hepatocellular carcinoma. Dr. Arora, please.
Thank you, Professor Saraswat. First of all, let me be very grateful to our team of Dr. Vivek Saraswat and Dr. Govind Makharia for having given me this opportunity. I am blessed to be presenting the topic in front of my teacher, philosopher and guide, Professor Saraswat, as well as my colleague from Alma Mater, Dr. Govind Makharia. The topic of my presentation is management of hepatocellular carcinoma. I am going to discuss briefly about the epidemiology of the disease, the etiological factors which are relevant as of today. How do we do the surveillance for diagnosis of early HCC? Because it is important to understand, unless we diagnose the disease in the early stage, further treatment is futile. How do we establish the diagnosis of hepatocellular carcinoma, especially in a complex situation of cirrhosis of the liver, And once you have been able to diagnose, what are the current modalities for management of the disease? Finally, I'll end up by telling you how to prevent the disease, as I sincerely believe that 80% of the HCC which is present today is manageable to prevention alone. And finally, we'll have a glimpse into the future therapies. Hepatocellular carcinoma is the fourth most common cancer causing mortality in the world. 2/3 of the patients with HCC tend to remain localized in the Asia Pacific and Sub-Saharan Africa region. The 5-year survival of the disease is pretty dismal, as majority of those who present to you for the first time, they present you in advanced disease. Except in a country like Japan, the country which has an excellent surveillance program, as of today, 30% of their newly diagnosed HCC patients are in the early stage of the disease, which is curative. This is the typical presentation which we have today in day-to-day practice in India. First time presentation comes with extensive involvement of the vascular system. And this is a case we reported in which the first presentation of the patient with HCC was Budd-Chiari syndrome because the tumor had infiltrated into the right hepatic vein and subsequently into the inferior vena cava. What is the etiology of HCC? Both cirrhotic and non-cirrhotic patients can lead to development of hepatocellular carcinoma. Hepatitis B, hepatitis C, NASH, and alcohol are the front runners for causation of cirrhosis, which leads to development of HCC, in addition to the list of other causes which I mentioned here. I think it is important also to remember there are non-cirrhotic conditions like hepatitis B, C, and NAFLD, which lead to development of HCC. In fact, in the natural history of in the cirrhosis of the liver, about 1/3 of the patient will develop hepatocellular carcinoma. And this rate is variable depending upon the etiology of the disease, and it varies between 1.5 to 3% per year. And this is the etiological breakup. And if you see hepatitis B, hepatitis C, alcohol, and obesity, and as I have mentioned, I sincerely believe we can tackle all of this and prevent the menace of hepatocellular carcinoma, which is running havoc in society of hepatologists. We reported this data of 140 patients from our center, in which we have shown that hepatitis B tends to cause cirrhosis of the liver as well as hepatocellular carcinoma much earlier than the other etiological reasons. How does a patient with hepatitis B, C, or alcohol result in formation of hepatocellular carcinoma? There are two mechanisms. All these patients with hepatitis B, C, and alcohol, they can produce hepatocellular malignancy by causing first inflammation, fibrosis, cirrhosis, and during this process of inflammation and fibrosis, there is an incidental and accidental damage to the DNA, mitochondria, resulting in endoplasmic reticulum stress. In addition, at least 2 viruses, hepatitis B and C, are known to induce both the genetic and epigenetic changes, and hence can lead to development of hepatocellular carcinoma, bypassing the development of cirrhosis of the liver. So do we need to have surveillance in hepatocellular carcinoma? Answer is yes. For any disease, to have surveillance, you need to have some specified criteria. And this criteria include that the disease has to be common, the diagnostic modality should be affordable, it should be acceptable by the general population, it should be effective in treatment of the early disease which we have picked up by this diagnostic modality, and incidence should be good. Fortunately for us, HCC fulfills all these criteria. That means the incidence is more than 1.45% per year, and you gain at least 100 days, that is 3 months of longevity at a cost of less than $50,000 per year gain in the life in hepatocellular carcinoma. So which patients need surveillance with hepatocellular carcinoma? The first and foremost is all cirrhotics should be screened for incidental HCC on surveillance, except the patients who are in the child C and who are not ready for liver transplantation. In subgroup of the non-cirrhotic patient, all patients with hepatitis B who have active inflammation, who have a family history of HCC, who have age of more than 40 years in males and have Asian or African descent should be screened for hepatitis B. In fact, there is also a recent suggestion that patients with advanced fibrosis and NAFLD in the form of NASH are also likely to have higher incidence of development of hepatocellular carcinoma. How do we do the surveillance? There are two methodologies which are available, serological and radiological. In serological, the most important modality is the alpha fetoprotein, whereas in radiology, the best modality is ultrasonography. Let me tell you something which is so important about alpha-fetoprotein. 10 to 20% of the patients with hepatocellular carcinoma at a stage where his surveillance is picking up the tumor will be positive for hepatocellular carcinoma. In addition, levels of alpha-fetoprotein will be abnormal because of the disease activity in hepatitis B and C and because of the regenerative capacity of the liver. So these levels may be abnormal. Alpha-fetoprotein, if you add it up to the ultrasound in diagnosis and increasing the sensitivity of ultrasonography for picking up early HCC, it only adds up 6 to 8%. And we still do not know what cutoff you use. If you use a lower cutoff, you have high sensitivity, low specificity. If you use a higher cutoff, you have higher specificity and lower sensitivity. And hence, all these three major international guidelines for surveillance in HCC still do not give a clear answer. But in practice, we still tend to use because it's easily available. The next best method for survey, in fact, the best method today for surveillance of HCC is ultrasonography, which is cheap, easily available, is cost effective, and has a good overall pooled sensitivity for diagnosis of HCC. The size of the tumor which is picked up by ultrasonography is extremely important, even though it picks up the smaller lesion at a much lower sensitivity level than the bigger lesion. But overall pooled sensitivity is high, and there is an excellent study published from China in which even though the compliance with this type of sequencing and the surveillance program was only 57%, but this is the best study ever published in hepatitis B positive patient, which has clearly shown that if you follow up these patients over a long period of time, there is a 37% reduction in the mortality of HCC, primarily related to early detection by ultrasonography, and these are the patients who are amenable to surgery. So what do we do to the patients who are incidentally found to be positive for hepatocellular carcinoma as seen on ultrasonography? There are three modalities which are available to us: contrast enhanced ultrasound, CT scan, and MRI. MRI and CT scan, there is nothing to choose between the two, except the good data shows that MRI, especially if you are using a hepatospecific contrast or using a diffusion weighted imaging, gives you better results if you are trying to pick up a lesion which is smaller than 2 centimeters in size. And this is just the data of all size versus less than 2 centimeter tumor. If you see the specificity of all three modalities, contrast enhanced ultrasound, CT, and MRI are equipotent in diagnosis, whereas in tumor less than 2 centimeters, certainly MRI scores over other. And hence, all international guidelines do tell us there is not too much to choose between the two modalities. How do we diagnose hepatocellular carcinoma? In fact, this is the only malignancy which does not require a tissue diagnosis for confirmation of the lesion. You can make a radiological diagnosis, but you need to understand the prerequisites. These prerequisites are that you need to have an underlying cirrhosis, you need to have a lesion which is more than 1 centimeter in size, and you need to have a lesion which shows arterial phase hyperenhancement and a venous washout. This is the arterial phase hyperenhancement and a portal vein washout. If you can satisfy these criteria in a cirrhotic patient, you don't need to have a biopsy. And recently we have started using this LIRAD testing, which is the liver imaging, reporting, analysis, and data reporting. So this is the method by which we have been reporting the various type of liver as well seen in patient with cirrhosis of the liver. Suffice is to say that if you have a diagnosis of L1, LR1 and 2, you are absolutely certain that you are ruling out a malignant lesion. If you are having a lesion which is LR5, you are absolutely certain that you are talking of HCC. Intermediary lesion need to have something which needs to be done. So this is the way LIRAD is reported. If you look at this slide, it looks very intimidating, very busy, but just 2 points are there in the slide which I'll try to impress upon. The first and foremost is that you need to have arterial phase hyperenhancement to call it HCC. So any lesion, irrespective of the size, if it does not have APHE, it cannot be HCC. Second is any lesion which is, it has to be more than 1 centimeter. So any lesion which is less than 1 centimeter, even if it shows arterial phase enhancement, cannot be HCC. So for HCC to be diagnosed radiologically, you have to have a lesion which is more than 1 centimeter and has to have all features which are established. We recently published these LIRAD guidelines in association with the Indian Society of Radiology, but somehow still I do not know why these are still put in the cupboard and most of us have not been using it. What do we do to a lesion which is less than 1 centimeter or more than 1 centimeter, which is picked up incidentally on ultrasonography? If it is less than 1 centimeter, I said it cannot be called HCC. So you just followed it up after 4 to 6 months, repeat an ultrasound. If that is normal, then you can repeat it again after 4 months. But if the ultrasound image shows a change in the pattern of the lesion, or if it increases in the size, then you have to do one of the confirming modalities. And these include other radiological investigation like MRI or contrast enhanced CT scan. So if any of these, either a CT or MRI, shows classical features of arterial enhancement and portal venous washout, you can confirm a diagnosis of HCC. If one of the modalities is negative, you can choose second. If both are negative, still you should do a biopsy in a lesion which is more than 1 centimeter. Only if the biopsy is negative, you can just follow it up for a period of time. The important message for this is, it is important to remember that there is an exponential poor prognosis after 2 centimeter. Anything beyond 2 centimeter, there is an exponential spread of the lesion in the vicinity and vascular involvement. So diagnosis at a stage up to 2 centimeter earlier is extremely important. So these are the indications for biopsy. Any lesion which is indeterminate or any lesion which is not conclusive on radiology needs a biopsy. And once a biopsy has been obtained, we need to do the staging of the disease. For staging of the disease, we need to have assessment of the tumor size, performance status, and the liver function. So on paper, we have this excellent BCLC staging, that's Barcelona Clinic of Liver Cancer staging, which gives you excellent answers. So you have early stage, you have intermediate stage, you have advanced stage, and a terminal stage. And with a clear-cut survival advantage, 60 months, 30 months, 10 months, and 3 months. Very easy to remember. So why should we have fuss about managing hepatocellular carcinoma? Just look at this slide and start treating. But problems we should understand, hepatocellular carcinoma is a heterogeneous disease. One size does not fit all. And you just cannot look at this slide and start treating the patient. And hence there are 3 important messages for, and we should understand that there are parentheses put in these slides which say the performance status and preserved liver function and optimal surgical candidacy. This is something which we have to understand as a hepatologist rather than just using the slide for management. Starting with the performance status, ECOG status, that is European Cooperative Oncology Group. What is it? I think this is a very good cartoon to understand what does it mean. ECOG would mean that a person is absolutely normal. You rush to office for working. ECOG 1 is when the person is not able to do the strenuous work and can do a light office work. And I think most of us as consultants who are not going to the senior consultants who are not going to our ward these days are possibly in the ECOG 1 state. In ECOG 2 status, you are not going to the office, but then you are able to take care of yourself completely. In ECOG 3, more than 50% of the time you are confined to the bed. ECOG 4, you are completely confined to the bed. You are not able to take care of your own self. And finally, ECOG is the stage of death. Preserved liver function means a CTP of 8 or CTP-B of less than 8 without ascites. Whereas optimal surgical candidacy means you should ensure that the patient's mortality should be less than 3%, morbidity should be less than 20%, and the post-op surgical risk, that is decompensation, should be less than 5%. So how do we manage based on these modalities? We need to have a multi-speciality team which takes into consideration the availability of the local modalities for treatment, consensus on the different modalities which are available. And fortunately, we are lucky to have a Zoom-based tumor board meeting in Sir Gangaram Hospital for almost 2 years, requiring the services of both the national and the international faculty to give the best to our patient. We come back to the same slide again, and to start the managing patients in the early or very early HCC, we need to have curative therapy. That is, this is the subgroup of the patient who can be cured. The various modalities include ablation, surgery, and liver transplantation. Starting with ablation therapy. The first and foremost is the percutaneous ethanol injection. And I'm happy to inform you that our Professor Acharya at AIMS was a proponent of this therapy, which causes coagulation, chemical coagulation necrosis of the lesion, and is very effective up to a tumor size of about 2 centimeters. Radiofrequency ablation is the standard of care in ablative therapy. It gives you heat-generated coagulation necrosis, but it has a limitation of not being useful in patients who have a lesion which has a arterial or the venous vessel going along it because of the heat sink effect. but it is better than PEI, especially if the lesion is more than 2 centimeter. Microwave ablation is another technique which has recently come into being. It uses electromagnetic energy to give you higher temperature. There is no problem of the heat sink effect, unlike in radio frequency ablation. But only thing is, because of the cost and because of the prospective trial not showing its benefit over and above RFA, we still use RFA as the treatment of choice for ablative therapy. Then recently there's a new modality called high intensity focused ultrasound. This is a new technique. If it is established well, then this could be even at primary center using a single ultrasound probe, even at the time of diagnosis of HCC. If a person can be trained, you can do a curative therapy right there at the time of diagnosis. With that, I think we'll take a break. We'll have one question. Can I present the question, Professor Saraf?
Yeah, I think we can see the question.
Yeah, the question is, the diagnosis of hepatocellular carcinoma can be made radiologically in the presence of all except. The options are A, arterial enhancement, arterial hyperenhancement. Second, portal venous washout. Third, underlying cirrhosis. And fourth, size less than 1 centimeter. With that, I'll stop sharing my screen and come back to Professor Vivek and Dr. Govind.
So you can respond to this questionnaire. Amol, if you have answer to that question.
Do we have a poll result?
I will get the full result soon. But meanwhile, Dr. Krishnadas, you can start you got a lot of questions.
Yeah.
So maybe we ask some questions here.
Dr. Anil, wonderful talk till now. And we have a few questions for you. Can I go on with the questions?
Yeah.
Dr. Anil, am I audible?
Yeah.
First question is from Patna by Dr. Vijay Shankar. Is there any role of combining tumor markers in diagnosis or screening of HCC?
Yeah. In fact, there are two ways of looking at this question. If you want to do the surveillance, diagnostic markers do not have any role. There is a new upcoming concept of liquid biopsy. This is a publication I'll be showing from Dr. Arun Sanyal's group, that using 8 miRNAs and 1955 signatures of the genes. Now, using an extracellular vesicle assessment of the DNA and RNAs within the blood and the urine, you can have a 98% specificity and sensitivity of diagnosis. As of now, if you want to use PIVCA2 and DCP and alpha fetoprotein L3 fraction, it is useful only to assess recurrence of the lesion after curative therapy or to diagnose advanced disease. They have no role in diagnosis of early disease.
Okay, so another question is regarding treatment. You have mentioned that there is RFA is better than microwave. The question was, which is better for a 3 centimeter lesion? Is it RFA or a second generation microwave? This is Dr. Nibin from Trivandrum.
There is no doubt, up to 3 centimeter, all ablative therapies are equally good. PEI is, that is alcohol injection, is useful up to 2 centimeter. Beyond 2 centimeter, up to 3 centimeter, RWA and microwave ablations are equally good. Advantages of microwave ablations are that it does not have you don't need to have a plate for counteraction of the current, and there is no heat sink effect. But prospective trials have not shown the utility of MWA over the RFA. And because of the cost benefit, we still prefer RFA.
Okay, sir. Next question is from Dr. Anil Kumar from Mysore. This is about screening. In patients with HPV without cirrhosis, when should you start screening?
Absolutely. I told you, any patient, we have given clear answers to that. Any patient who has a persistent inflammation, males more than 40 years of age and family history of hepatocellular carcinoma, African ascent, these are the patients who need regular screening. So age more than 40 years, family history of hepatocellular carcinoma, in the absence of the cirrhosis, do need screening and surveillance.
And the question is from Calcutta by Dr. Bhavik Shah. Is there any role of PET in the diagnosis of 1 centimeter HCC? Very
good question. You see, the problem is, if you look at the total spectrum of hepatocellular carcinoma, PET will pick up only about 40 to 50% of the patients. Well differentiated HCC, if you see the way I have shown you the hepatocarcinogenesis, HCC developed from a dysplastic nodule which occurs because of persistent inflammation. So the first diagnosis will be well differentiated carcinoma, and then in them, majority of the time PET will be negative. So by the time PET is positive, you already have a poorly differentiated carcinoma, or there is evidence of extrahepatic or vascular invasion. So PET has no role in diagnosis of early HCC, very clear.
Again, for screening and surveillance, from Prashna Anirvan from Dibrugarh, is there a need for surveillance for HCC in a non-cirrhotic patient with portal vein thrombosis?
In portal vein thrombosis?
Yeah, in a non-cirrhotic patient with portal vein thrombosis.
No.
Is there a need for surveillance?
So if there is no cirrhosis of the liver, then it depends on the etiology of the portal vein thrombosis. Most of the time, I look for a hypercoagulable state rather than trying to screen for HCC in a situation like this.
Another question on staging from Dr. Aditya Kale from Mumbai. Which is the better staging system to be used in India, BCLC or HKLC?
I think most of us are so used to using BCLC. That is the best and most validated, prospectively validated system in the world. In fact, we have, if the time permits, and if Dr. Vivek and Dr. Govind permit me, we have designed our own algorithm, which is much easier than BCLC. I think the moderator permit will show them our own staging system.
Do you have it with you now, or can you have it later? At the end of the talk?
Yeah, at the end of the talk.
Okay, sir. Then one more question. One more question. Is the time for one more question, Dr. Govind?
Yeah. Yes, please. Yes, please.
Yeah, can we use, this is from Varanasi by Dr. Piyush Thakur, can we use BCLC classification in non-cirrhotic HCC as IBCLC requires CTP score?
You see, a non-cirrhotic HCC is a totally different ball game. If you want, I can present data on that. It typically occurs in larger forms. Most of the time, by the time it presents, the lesions are larger. Alpha fetoprotein is typically not elevated. Most of them do not invade the vascular pattern because the liver function is preserved. Surgery is primarily the answer. But in terms of radiological changes, there is nothing much to choose. They will have the same radiological features whether they are in cirrhosis or non-cirrhosis.
One more question from Trivandrum, Dr. Sunil Raviraj. My relative is HCV related cirrhosis, child A and men 11 with an AFP of 170. Age is not given. Ultrasound did not show any space occupying lesion, but CT dynamic review showed a 9 mm dysplastic nodule. What should we do now? Should we do an MRI now, or should we wait for 1 month then to recheck it?
Yeah, see, if I have shown you very good algorithm of management of a lesion which is less than 1 centimeter.
But here the problem is his AFP is 170.
Yeah, I'm coming to that. Only caveat you have is a raised alpha fetoprotein. Now you should understand raised alpha fetoprotein can also occur in an active inflammation, which may be occurring because of the hepatitis B and C. So in a situation like this, I'll see whether the patient has a replicative marker or not. If the patient has an ongoing replication evidence in the form of hepatitis C replicative status, then you can follow up of this patient. If the RNA is negative, then I'll go in for another modality like MRI or CT to confirm it. Up to 1 centimeter, theoretically, you can leave it alone and let it come to 2 centimeters, because it has been shown that if you try to intervene prior to 2 centimeters, there is no more advantage. Beyond 2 centimeters, there is an exponential rise. So there is no harm in waiting and coming back with another CT after 3 months.
I think if we go on now with your presentation,
Okay.
Professor Arora, I think we can take other questions at the nearer the end of your talk.
Yeah, there are many more questions. We will have it later.
Is the screen visible, sir?
Yes.
Okay.
You saw the answer. Everybody answered size less than 1 centimeter.
Answer is very clear. I think it is a simple one. The next curative option is surgery in patient with hepatocellular carcinoma. Whenever a patient comes to you with a tumor, as a hepatologist, 2 things are important to understand. What is the number and extent of the lesion, which can be assessed by the dynamic CT scan or PET or whatever you want to do. And secondly, you have to assess the child status of the disease by a MELD score or a CTP score. So whenever you want to operate on a patient with hepatocellular carcinoma with a cure to with an intent to cure the patient, this is what you have to satisfy. Peri-op mortality has to be less than 3%. morbidity should be less than 20%, and the chance of post-op liver failure should be less than 5%. This can be achieved if you have a CTP of A or MELD of less than 10. So this is what we decide whether the patient has portal hypertension or not. If the patient has no portal hypertension, and if you're doing a major resection, then you have a intermediate risk. If you have evidence of portal hypertension, then minor resection is characterized by less than 3 segment resection, whereas major resection is characterized as any patient undergoing a surgery with resection of more than 3 segments. So there is a beautiful graph which shows that depending upon presence or absence of the portal hypertension and the MELD score, the total risk varies. It is extremely important to understand this risk before going in for surgical resection for curative attempt of HCC. So if you are doing a minor resection, no portal hypertension risk is minimal. If you are doing a major resection, that means you are removing 3 segments in a patient with a MELD of more than 10, then more than 9, then you are having a significant risk of decompensation up to the tune of about 26%. So the current recommendations are, if you are having child A without clinically significant portal hypertension, characterized as HPPG of more than 10, esophageal varices or splenomegaly, or platelet count of less than 1 lakh. So major resection should be done only if patient has child A without clinically significant portal hypertension, whereas minor resection should be attempted only in child B and selected patient with clinically significant portal hypertension. Preferably, given the choice, if you have a good laparoscopic support, there is good data to show that laparoscopic surgery is better than open surgery. What about RFA versus local resection up to a size of 3 centimeter? In fact, it has been clearly shown in various meta-analysis that up to a size of 3 centimeter, local ablative therapies like RFA can give you equally good result in terms of long-term efficacy for management of curative intent in patients with hepatocellular carcinoma. Third curative attempt is liver transplantation in patients with hepatocellular carcinoma. In fact, ideal treatment, very well documented over almost 15 years from the French group, is the first line option of Milan's criteria, and which has shown excellent 5-year results to the tune of about 65 to 80%. And this is also the reason why should we downgrade or bridge our patient back to Milan criteria if we want to do the liver transplantation. In fact, but in patients with LDLT, especially in setup like India, where we have 80% of our transplantation are LDLT related, there is more liberal policy of using liver transplantation in LDLT, and at least 2 other than Milan, UCSF criteria in some center has also been validated. And this includes the criteria has shown that you have a lesion which is more than less than 6.5 centimeter, and the single lesion has to be less than 5 centimeters. So Milan and UCSF criteria can be taken up in selected center in living donor liver transplantation. In fact, in the Western world, so-called marginal donors are supposed to be equally good in DDLT program. And these marginal donors are the donors in which you have a living donor right lobe graft, cadaveric split livers, organs with steatohepatitis, and also the organs which have been retrieved from circulatory death donors as against brain dead donors. Living donor liver transplantation has a chance of recurrence of the disease, and in fact the best results are obtained if you do the transplantation within Milan's criteria. We will usually recommend that if the lesion is beyond Milan criteria, we should do a downstaging of the disease. That gives you 2 advantages, that you are doing it on a criteria which has been prospectively validated, but it also gives you time to study the biology of the disease. Most of these patients with hepatocellular carcinoma who undergo liver transplantation do need a regular follow-up, because there is an incidental recurrence of tumor in about 8 to 20% of the patient. And most of these patients tend to recur within the first 2 years, and majority of the recurrences are within the liver, and they tend to occur because of the reactivation of the underlying liver disease or metastasis which has been missed previously rather than the de novo metastasis. Next stage of management is BCLC-B. That means you have a multinodular lesion which is not resectable, but fortunately for us, patient is still as having preserved liver function and ECOG status is good. So we need to have a locoregional therapy. classical locoregional therapy is called TACE, that is transarterial chemoembolization, which involves catheter-based delivery of the chemotherapeutic agents, followed by injection of the embolic material so as to decrease the arterial flow. So these are the various embolic agents and the chemotherapeutic agents which are available in the market, which are used in day-to-day practice in interventional radiology. Suffice to say that a new drug called idrarubicin has the maximum potential. It is still being tried in phase 3 trial. This has the maximum activity in vitro against the hepatocellular carcinoma. So there are various types of TACE which can be done, conventional TACE versus drug-eluting beads. And in conventional TACE also, depending on which particular part of the artery you are going to embolize and cause ischemia, the results can improve. The indications of TACE are that all patients who are having a BCLC stage, intermediate stage, or those patients with BCLC A, in which the ablative therapy or resection therapy have led to stage migration and there is a recurrence of the disease, or patient in advanced stage of the disease in the child, in the larger tumors who need to be downgraded to be brought back to the Milan criteria. These are the indications for TACE. But if the patient has a CTP of more than 8, extensive main portal vein thrombosis, creatinine of more than 2, or extensive tumor involving both legs, this should not be undergoing TACE. We recently published our results in selected subgroup of the patients who underwent TACE even with portal vein thrombosis. Another advantage of using TACE is that you can either downstage the tumor. That means you bring the tumor to within Milan's criteria, or bridge the tumor if the waiting period for DDLT program is more than 3 months, so that there is no increase in the size of the tumor, because the larger the tumor, the more progress if the tumor prior to liver transplantation, higher will be the chances of the recurrence after liver transplantation. With downstaging and bridging, what you are trying to achieve is a 100% necrosis, which unfortunately is possible only in 30% of the cases. So there is TACE is associated with complication. Most of them are easily manageable. We presented our audit in about 300 patients undergoing TACE in our center, which showed relatively good results. There is no added advantage of drug-eluting bead, though the theoretical advantage is that if you are using beads as carrier agent of chemotherapeutic agent, the side effect will be less because small amount of the chemotherapeutic drug is released at a time. But prospective trials have not shown the benefit of drug-eluting bead over and above the conventional TACE. There is one score called HAP score, that is hepatoma arterial embolization prognostic score, which tells you what is the outcome of the TACE. So a combination of albumin, alpha-fetoprotein, bilirubin, and maximum tumor size. Very easy to understand. Larger the tumor, higher the alpha-fetoprotein, more the albumin, lesser the chance that the TACE will be successful. The chances of recurrence will be very high. Another vascular modality is called transit arterial radioembolization or TARE. Advantage is that you are using microspheres which travel deep into the smallest possible capillaries, because the size is only 35 micron. And since the hepatocellular carcinomas are lying just in the vicinity of this distal capillary venule, so you have these beta emitting microspheres which can be very effective in management of hepatocellular carcinoma. Important thing to note is that you are not causing ischemic injury to the liver, and hence theoretically it should have more advantages as compared to TACE. But the problem with the TARE is that none of the guidelines has still recommended it over and above the TACE. The reason is that it is possible to do TARE only in about 2/3 of the patients who are eligible for it, because if there is a shunting of the blood away from the liver, or if there is a history of biliary obstruction, TARE cannot be done. There are some studies which have tried to look at the advantage of combining TACE with systemic therapies. Unfortunately, none of them have shown any benefit, but the TACTIS trial has recently suggested that if you do not use M-RECIST criteria for follow-up patient with HCC, there is some advantage of using sorafenib over and above TACE. Finally, coming to the systemic therapies in patients who are having in the stage C, that means there is an extension of the tumor into the portal vein, or if there is evidence of the extrahepatic spread, but still the performance status is less than 2. What do we do in such condition? There are extensive ways of development of HCC. How many tumor factors you can block is not easy to understand. And hence you look at the timeline of development of the systemic therapies in hepatocellular carcinoma. But just to summarize, we took 30 years to discover the first drug as a first line therapy of HCC, that is sorafenib. Subsequently, we took another 10 years to develop the second first line drug, that is lenvatinib. But then if as a hepatologist, I look at it, survival advantage is only 3 months. Is that not a food for thought for us as hepatologists? So what do these what do these TKIs tell us? They tell us that minimum dose required is around 800 milligram per day. Only 15% of the patient do not tolerate these disease. In 35%, you have to reduce the dose. Overall response rate as seen on M-RECIST is only 10%, and advantage you get is only 3%. So this is the second line drug which have come. So if the first line does not work, second line can be used as cabozantinib, regorafenib, or ramucirumab. If the disease is progressing and the patient is tolerating the drug, then regorafenib. If the disease is progressing in patient who's not tolerating, then you can use cabozantinib, and then there is some role of immunotherapy. So what is the basis of immunotherapy? So this is something I think is important to understand, because most of the new upcoming therapies will have immune check inhibition. So let's look at what is happening in patients who have tumor. So if you have a tumor, it will release an antigen called tumor antigen, which will be processed by the dendritic cell, which will be presented to the MHC cell, that is major histocompatibility antigen. Now this antigen, this cell ideally should look at the T cell, try to activate the T cell, which will in effect kill the tumor cell. But what happens before activation of the T cell, you need to have stimulation of the co-stimulatory molecule, especially in the form of CD80. So this CD80 of the dendritic cell has to come in contact with the CD28 of the T cell. Unfortunately, CTAL4, which is an inhibitory molecule, tends to block the attachment of the CD80 to CD28. So what you can do is you can get a anti-CTAL4 antibody. That is a classical ipilimumab in treatment of hepatocellular carcinoma. And then once you have activated the cytotoxic T cell, how is it that is going to kill the tumor cell? You need to have a combination of the antigen expressed onto the T cell receptor, which will then identify tumor cells. But for that identification, you need to have free PD-1 sites. Unfortunately, tumor is very smart. It tends to produce these ligands called PD-L1, which tend to block PD-1. So if you can antagonize either PD-1 by nivolumab or pembrolizumab, or you try to undo PD-L1 agonism by durvalumab, this is the time when you have T cell which will secrete the enzymes called perforin and granizin, which are going to kill the cell. So this is the concept of the immune checkpoint inhibitors, which are available in the market, which are going to be available soon in the market. And only yesterday evening, this was a publication on 19th May 2020 from New England Journal of Medicine, a combination of atezolizumab and bevacizumab in resectable carcinoma gives you a 15-month survival. Radiotherapy has a limited role. So EASL and ASLD still are not convinced about its utility in patients with hepatocellular carcinoma. We tend to use it in subgroup of the patient who have tumor thrombosis in hepatocellular carcinoma. And finally, in patients who have hepatocellular carcinoma, as I said, unless we prevent them with lifestyle modification, stopping consumption of alcohol, hepatitis B vaccination, and treating hepatitis B and C, you cannot prevent HCC. Look at this slide. Just by hepatitis B vaccination, you have a 70% reduction of HCC. So if you treat with nucleoside analogs, DEAs in HCV, stop alcohol, do the activity, take aspirin, you have a substantial reduction of HCC. This is extremely important. And finally, coming on to the role of coffee, clear answers from EASL and the ASLD recommendation: 2 extra cups of coffee, they decrease the oxidative stress and decrease there is a 30% reduction in risk of hepatocellular carcinoma in patients who drink at least 2 cups of the coffee per day. And in future lies in the early marker, that is liquid biopsy. This is the publication from Dr. Arun Sanyal, which I have partly answered earlier, a combination of number of tumor-associated protein biomarkers as well as mutation in 1933 distinct genomic patterns, which can be picked up in extracellular vesicle, both in the blood and urine, gives you 98 to 98% sensitivity and specificity for diagnosis of early HCC. So with that, if the chair permits, can I ask 2 questions, sir?
Absolutely. Yes, please.
So the first question is, nivolumab is the immune checkpoint inhibitor which acts at CTLA4, VEGF, PD1, PDL1. Dr. Govind, can I move to the next question?
Now, let's see the response to this. So we can have a response from Amol to see that what is the response like from audience. Yes, Amol, you can share your screen. So everyone said almost 60% said PDL1.
Nivolumab is not PDL1, it is PD1. Okay.
Amol, can you show the slide once more? Actually, did I read wrong? Amol, can you show the slide again? Yes. So this is this one PD1 as a response. Almost 60% is PD1. Anyway.
Yeah, that's good. So I think my explanation was good enough.
Absolutely.
Okay. Then we move on to the next question. Next question is, a patient who was on sorafenib 800 milligram per day developed significant side effects and disease progression. So as per the EASL ASLD guideline, what should be the second line systemic therapy as a treatment of choice? Answers are lenvatinib, cabozantinib, regorafenib, or continuous sorafenib.
Can we have answer, please? Yes. So answer that regorafenib, 26%, 25%, and almost 50%.
Inclusion criteria for regorafenib was subgroup of the patient who tolerated sorafenib for at least 28 days prior to the start of the trial in a dose of at least 400 milligram a day. So if you are sorafenib tolerant and disease progression, answer is regorafenib. Can I move on, sir? And finally, to summarize, hepatocellular carcinoma is the leading cause of cancer-related mortality and incidence is rising. Surveillance of patient at risk for hepatocellular carcinoma should be carried out by ultrasonography every 6 months. Lesion less than 2 centimeters, if you have the advantage of the hepatospecific contrast agent like gadoxytic acid and the advantage of using a DWI, that is the best modality for diagnosis of HCC less than 2 centimeters. Surgery is the treatment of choice for very early HCC and HCC in non-cirrhotic patients also. There is no role of adjuvant chemotherapy. After that, radiofrequency ablation is equal to surgery for all lesions less than 3 centimeters if they are candidate for surgery. TASTE is the modality of choice for BCLC-B as well as to downstage or bridge the therapy. Milan criteria is the most definitive and prospectively validated criteria for selection of the patient for liver transplantation. 8 to 20% of these patients are likely to recur after liver transplantation. Most of the patients with portal vein thrombosis cannot undergo TACE, and hence TARE can be an alternative therapy, and TARE can be used in addition to radiotherapy in patients who have a portal vein thrombosis and hepatocellular carcinoma. Systemic therapies do have a limited role, at least to my knowledge. There is an increasing role of immunotherapy, which has been promising over the last 8 to 9 months. and prevention of HCC with control of HBV is extremely important, as 80% of the HCC can be prevented. And finally, with the availability of liquid biopsies in molecular genetics, we may be able to diagnose HCC much earlier in patients with hepatocellular carcinoma. To end up, sir, optimism is the faith that leads to achievement. Nothing can be done without hope and confidence. With that, I'll hand over the stage back to the organizers. Thank you so much.
Well, thank you very much, Anil, for a masterly overview in the short time of this extensive topic of hepatocellular carcinoma. You've covered many areas, including the recent progress on newer drugs and combinations and diagnostics. And as is to be expected, you have a flood of questions to answer.
Can
Over
I
150
just
questions
propose
have
my
come in.
algorithm, if you allow me?
I think what we could, it would have been nice if you had got it into your talk, because I think about 150 questions that have to be
We'll go ahead with question and answer.
addressed. We would like to have some time for the people who have been working hard to put very difficult questions to you. So I think I'll just divide them into a few categories. I'll take about 5 or 7 questions, and then Dr. Ajay Jan will have more questions for you. People
You can
ask
use a
questions, so they
filter
want
and
you
you can
to
use
give
difficult questions
answers.
for yourself.
Right. So I think in terms of diagnosis, people want to know what is the benefit of combinations of markers like AFP, AFP-L3 and PIVCA. Does it increase the screening sensitivity? Is it cost effective? What are your thoughts? This is Ravi Thakur from Banaras, Varanasi, wanted to know.
It has no role in diagnosis of hepatocellular carcinoma. But when you plan therapy like surgical excision, tear, or liver transplantation, it does have a role. Biggest advantage of using DCP and alpha fetoprotein fraction, L3 fraction, is to characterize the lesion which are likely to recur, have poor prognosis, and may be unfit for liver transplantation. Most of these patients who have positive markers like DCP and alpha fetoprotein L3 fraction are having poorly differentiated carcinoma. They don't have no role in diagnosis, but certainly in management, they are of help.
Okay, thank you. And I think Dr. Ravichandra from Hyderabad, Ravichandra wants to know, how will you differentiate a multicentric HCC from a single HCC which has metastasized to multiple lobes of the liver? Multiple intrahepatic metastases of an HCC.
Yeah, I think the best, I told you in terms of specificity of the lesion, all 3 lesions is specifically picked up by CT, MRI, and EUS. So whether the patient has a one lesion which has metastasized, as multiple metastases, there is no way to know unless you have a previous ultrasound or CT scan or MRI, which shows that there was one lesion which has gone up. So multicentricity of the lesion in one scan cannot be documented.
Right. But if you have one large lesion and multiple small lesions, would that change things?
Yes. It's very important. The ultimate success of any treatment depends upon whether you have a satellite nodules. Satellite nodules, perivascular invasion do portend a poor prognosis. That is exactly the where the role of DCP and alpha fetoprotein fraction L3 comes in. Even if there are no satellite nodules, if on biochemically you can pick up these markers, these indicate more likely recurrence of the lesion. That means what you are seeing macroscopically, you may have more microscopically also.
Right. So, okay. And I think Dr. Ravichandra also wants to know that in a non-cirrhotic HCC, are imaging criteria sufficient, or you still need the help of tissue diagnosis in the absence of cirrhosis?
All patients with non-cirrhotic HCC cannot be diagnosed in the absence of biopsy. Radiologically, the features look like the same, but the radiological criteria has been specified only for cirrhosis and cirrhosis alone. I did specify in my talk, there are 3 requisites. You need to have an underlying cirrhosis, you need to have a lesion more than 1 centimeter, and you need to have a arterial enhancement at venous washout to say it radiologically.
Right. So you do need tissue in cases of non-cirrhotic suspicion of HCC.
On radiology.
Again, Ravichandra has a lot of imaging questions. He wants to know the cutoff value for fibroscan in a patient with cirrhosis alone versus cirrhosis plus HCC. Do the cutoffs change, or does fibroscan help you in making suspecting HCC?
See, absolutely. In fact, if you see in clinical practice, you hardly look at a fibroscan once you have a CT and MRI. it has no more advantage. Diagnosis of HCC has nothing to do with the fibroscan. As I said, in hepatitis B and C, advanced fibrosis can also lead to presence of HCC, even in the absence of the cirrhosis. So we never look at fibroscan to see whether the patient has HCC or not, because there is enough specificity available by three modalities: CEUS, CT scan, and MRI.
Right. Okay. I think there are several people, particularly Dr. Suprabha Giri from Mumbai, Rinkesh Bansal from Gurgaon, and a couple of others wanted to know about the Hong Kong HKLC versus the Barcelona clinic and the Hong Kong clinic liver cancer scores. In the context of Indian patients, how do you rate them? Would HKLC score above BCLC?
Yeah, you see, I have already mentioned that in Indian scenario, we have major chunk of our liver transplantation is LDLT. In DDLT, you have a Milan's criteria which has been most prospectively validated. There are some centers which have also validated UCSF criteria. There are centers in India which do not look at any of these criteria, and according to them, any lesion which is within the liver, if it has not invaded the portal vein, if there is no extrahepatic spread on MRI, CT, or PET scan, then the size and the location does not matter. But these have not been prospectively validated. But I will agree with this notion that if the patient child status is okay, and if you have a living donor, if there is no macroscopic invasion, then you can bypass these conventional criteria and can go beyond QCSF.
So bottom line, your HKLC in which situations and BCLC in these situations?
BCLC, as I said, in fact, you can go beyond BCLC in LDLT setting. LDLT setting, you don't need to be restricted to Milan or UCSF. You can go well beyond UCSF also. But then that has to be prospectively evaluated. If you look at the EASL 2018 guidelines, they clearly show anything beyond it it's not that you should not do it, but then you should prospectively validate it, especially in the external center rather than at a given center.
Okay, I'll ask you two quick questions about surveillance and then hand over to Dr. Ajay Jain for his set of questions. So Dr. Alok from Jalandhar wants to know regarding HCC surveillance in post-SVR HCV cirrhosis, hepatitis C liver cirrhosis post-SVR. Should it be any different from what you have suggested? Should it be more frequent? Because people have this impression that HCC is picked up more often in the post-SVR HCV group.
It should not be done more frequently, but it should not be done less frequently also. In fact, if you see, when DEA came into the market, I think Dr. Vivek was with me in the EASL meeting in Barcelona. There was a path-breaking abstract from Judy Borix from Spain, which said that, with DEAs, you have a rapid increase in carcinoma. But subsequently, I think there is enough data to suggest that these were the patients which were possibly missed in the earlier diagnosis of HCC, and then they later surfaced up. There is a good data to show DEA should not be restricted and withheld in patients with HCC. In fact, DEA should be started right at the time of diagnosis of HCC. There is increasing data to show that if you start DEA at the time of diagnosis of HCC, this only adds up in recovery of HCC. And after the DEA has been achieved and the SVR has been achieved, there is a substantial reduction in development of HCC. It's not that
so basically the question was about surveillance, not about DA treatment. So surveillance should be same as is there in people who have no change in the surveillance protocol.
Surveillance after SVR has been achieved.
Right.
Should not be
finally, when do you start surveillance in people with alcoholic cirrhosis and NASH cirrhosis, or people in NASH even without cirrhosis? What are your guidelines for surveillance in these people?
In fact, see, there is a criteria of efficacy of surveillance, which tells you the incidence of disease and the cost effectiveness of surveillance. In cirrhosis of the liver, if you are having 1.5% incidence, that becomes cost effective, which is calculated by two parameters. That is an increase in the life by about 100 days at a cost of $50,000 per year of the life saved. Now, cirrhotics do fit in with that criteria. Hepatitis B fits in with that criteria, whereas NASH fits at a borderline criteria. The incidence of hepatocellular carcinoma in NASH is to the tune of about 0.3% per year. And the cost effectiveness come at 0.2.
I think just stick to the surveillance strategy. What should be the surveillance strategy in NASH, non-cirrhotic, and NASH cirrhosis?
Yes, in NASH cirrhosis, the criteria is the same as in other cirrhosis. In NASH, in the absence of the cirrhosis, it is left to the individual. As I said, I've given you the justification why should you do it or why you should not do it. Up to 0.2% per year is justified to use it with the conventional available cost effectiveness. And in HCC, it is 0.3, but still it is left to the individual because there are so many other factors which affect the outcome, including the metabolic syndrome, diabetes, etc. in NASH.
Right. So I think Dr. Ajay Jain, if you are ready with your questions, please
Yeah.
ask them for Dr. Arora.
Yeah. The question from Dr. Varghese from Trivandrum. He wants to know role of nanoparticle technology in the diagnosis of hepatocellular carcinoma.
There is, as of to my knowledge, none of the guidelines do mention that. I have not come across any technology like this. What is important, which I mentioned you, is the liquid biopsy, recently published by Arun Sarnyal.
The next question is by Dr. Saxena from Delhi. He wants to know, is the management of hepatocellular carcinoma different in a pregnant female?
In
pregnant female.
In pregnant females?
Yeah.
Most of the therapies which can be given in hepatocellular carcinoma management, be it radiation, be it TACE, TARE, or surgery, will be contraindicated in pregnant women. So, systemic therapies have not been allowed to be used in pregnant women. So, you will have very limited options. Only thing which can be done is TACE. Only thing which can be done is an RFA in pregnant women, which may not be a contraindication. Short of that, radiation and surgery certainly will not be indicated in pregnant women.
So, next question is by Dr. Abhiman Pawar from Sangli. He wants to know what precautions one has to take using immune checkpoint inhibitors in post-transplant metastasis, as these drugs stimulate T cells, whereas patient needs immune suppression to prevent rejection.
In fact, after transplantation, there was some suggestion that if you use drugs like everolimus, so that is a mTOR inhibitor and gives you better results. But as of today, immunosuppression has been clearly shown to have no relevance in terms of progression or regression of the disease. Earlier, it was thought if you give mTOR inhibitors like everolimus, it will give you some advantage, but it has not been proven in subsequent studies. So you don't need to shift your immunosuppressive strategy.
The next question is by Dr. Prokhar from Varanasi, and he wants to know the role of stereotactic radiotherapy in locally advanced hepatocellular carcinoma. Can you throw some light on it, and also whether it can be combined with other well-established therapies?
The SBRT, I had skipped some of the slides because of the want of the time, because by default, it is a radiosensitive tumor. HCC is a radiosensitive tumor. So in our indication for use of SBRT are the location of the tumor, which is primarily in the hilum, and the tumor which is infiltrating into the portal vein. So portal vein tumor thrombosis with hilar lesion, which is unfit for TACE, is the best candidate for SBRT. In fact, there have also been trials to use SBRT as a primary standalone therapy in earlier stages of HCC, like child in the BCLC A and B, but these have not been prospectively confirmed and guidelines do not suggest it. So we are using it in subgroup of the patient, hilar lesion, unfit for TACE with tumor portal vein thrombosis.
There are a lot of questions regarding the role of PET scan in the diagnosis and management of HCC. A lot of questions. Less than 1 centimeter lesion, what is the role of PET? Lesion between 2 to 3 centimeter, role of PET. So can you throw some light, what is the exact role of PET scan in the diagnosis and management of HCC?
PET scan, I have told you, it has absolutely no role in early HCC. No confusion about it. Best way to diagnose early HCC is MRI. I've shown you clear images. It has the best sensitivity, especially if you use two types of additional advantages over and above the typical contrast agent. One of them modality is called hepatobiliary contrast. So this is a contrast called gadoxitic acidic contrast. Advantage of this contrast is in addition to give you extracellular component, it gives you a hepatobiliary stage. So in extracellular component, you are looking at the hyper enhancement, that is the vascularity of the tumor. And in the hepatobiliary phase, you are looking at the characteristics of HCC. Biggest advantage of this type of contrast is that in a dysplastic nodule, you will have complete receptor and transporters which will pick up the contrast and put it into the biliary tract. But the moment you have hepatocellular carcinoma, there will be no picking up of this contrast and then draining into the biliary duct. So by T2 imaging, if there is an HCC, it can beautifully be differentiated from this plastic nodule because of the functioning capacity of the gadoxetic acid.
Another question is by Dr. Prakhar from Varanasi, and he wants to know, does statin use along with NUC or DAS reduce the chance of hepatocellular carcinoma development in those patients who have HBV or HCV as etiology?
In the penultimate slide which I have showed you, the risk reduction with the various modalities, including abstinence of alcohol, hepatitis B and C, even though it is claimed that statins do decrease the portal pressure and fibrosis, but there is no quantitative risk reduction of HCC in addition to DA and HCV, no documented data. But then hepatitis B treatment, HCV treatment, alcohol abstinence, and aspirin do have reduction in different type of etiologically related malignancies.
So one of the question, I'm forgetting the name of the gentleman who asked, how this coffee works in prevention of HCC?
How does?
Coffee works in the prevention of HCC.
As which one?
Coffee.
Coffee, yeah.
Yeah.
Coffee, you see, there is data. Because of the want order, I skipped the slides. What it does is it stimulates the MAPK3 kinase and ERK2 kinase, thereby decreasing the oxidative stress. If you remember one of the slides I showed you, that the etiological agents can cause HCC either via the inflammatory cascade or directly by changing the genetic and epigenetic milieu of the cell. So when they are doing via inflammation, they go through a process of DNA destabilization, injury to the mitochondria and oxidative stress. That is where the coffee acts, convincingly shown that there is a 35% reduction. And that is the reason EASL has clearly recommended that if you drink more than 2 coffees per day, it does decrease.
So the corollary to that is, if a person is taking an alcohol every day, does he take 2 coffees every day, will reduce the chances of HCC?
I think maybe you'll have to drink both and see.
So couple of last questions. Dr. Deepak Bhangle from Kochi wants to know, the checkpoint inhibitors are known to cause hepatotoxicity. So how safe is to use them in HCC?
Yeah, I think it is an important question. If you look at the phase 3 trial, CheckMate 4759 trial, it has not shown any more advantage over and above the use of sorafenib. If you see, the US FDA had given a conditional approval based on phase 2 trials, but phase 3 trials have not shown advantages over and above sorafenib. So we are back to the square one. And I agree, 30% of the times if you have hepatotoxicity, it is a big issue because you are not only treating hepatocellular carcinoma in toto, it is you are doing it on an underlying cirrhosis. And most of the time the cirrhosis is advanced by the time you have these lesions.
Last question from my side, because this again has been asked by a large number of people, is more the role of PIVKA, that is a vitamin K associated tumor marker, in the screening of HCC. There are about 15 odd people who have asked this question.
Which marker?
PIVKA.
PIVKA.
Yeah, PIVKA is same as DCP. I told you, this is the des-carboxyprothrombin. It is an altered form of prothrombin. PIVKA2 and DCP is the same thing. Very clear answer. It has less sensitivity, more specificity. It tells you that there is a satellite nodule. You are more likely to have poorly differentiated tumor. You are more likely to have vascular invasion. So no role in diagnosis, excellent role in prognosis, surgery, recurrence, transplantation.
Last question. Please guide us in treating HCC in pediatric age group. This is by Dr. Sunil Raviraj from Trivandrum.
I have no experience. I'll not be.
Okay, so
there have been a lot of requests. People want you to share your HCC algorithm. We have a few minutes in hand, 2-3 minutes before we have to wind up. So could you quickly take people through your algorithm for HCC?
Yeah, I will have to, I think get back to the slide. Can I take 1 minute?
Yeah.
Okay. I'll just take 1 minute.
Meanwhile, the question is now 213, 213. So,
Lot of
Lots of homework for Anil.
Yeah.
You answered a fair number. You must have answered about over 20, 25 questions in the 3 sessions, but still about 180, 190 questions for you to deal at home.
There was one question that stands out. Can I ask it?
Yeah.
Yeah, please.
Yeah. What is the legal aspect of starting treatment without biopsy?
Without
This
biopsy.
is just a doctor from Chennai. No name. A doctor from Chennai has asked.
See, it is a prospectively validated study. Why are you worried about it? If this is the only diagnosis which can be made radiologically. So there is no legality. So far as you satisfy all the criteria, where is the problem of legality?
Probably somebody has given a case against him.
If you are confident, if you know your subject, you don't need to be afraid about it. Yeah. So this is the proposed classification.
Can you share the screen, please? Share the screen, please.
Is the screen available?
yes.
Yes.
So what we have proposed these criteria, which we are going to publish and have the opinion of everybody. So I think the best way to look at HCC after going through the whole gamut is, as the patient walks to you, just ask him a simple question. What is the PS? What is the performance status? If PS is more than 2, I've shown you the various caricatures and diagram of how to look at the PS. PS2 would mean that you are not going to office, you are stationed at home, and you are in bed more than 50% of the time. So in this patient, nothing can be done. The patient needs a supportive care. That is the question number 1. Once patient has a PS of 2 or less than 2, that is performance status of less than 2, you ask the patient, because patient will come to you with a CT and MRI, to look at the record and see if the patient has an extrahepatic spread or no extrahepatic spread. If the patient has extrahepatic spread, nothing can be done. Again, patient is pulled into a medical therapy or other thing which I'll come to. If the patient has no extrahepatic spread, third question you have to ask him whether the patient has a lesion within the Milan criteria or outside the Milan criteria. If the patient's lesion is within Milan criteria, we can ask him all of them to come to get a downgrading done and come back to Milan's criteria. Everybody within Milan criteria should be offered a liver transplantation. If they can do it, well and good. If they cannot do it, 80% of them cannot do it, then you look at the size of the tumor. If the tumor is less than 3 centimeter, ablate. 3 to 5 centimeter, ablation and TACE. More than 5 centimeter, look at the clinically significant portal hypertension. More than, if there is CSPH, then you do TACE, and if there is no CSPH, you can go in for surgery. And if the downstaging is not possible in patient who come to you with an advanced disease, look at the CTP. If the CTP is more than 8, nothing can be done. If the CTP is less than 8, then there are 2 options of either medical therapy or TACE. And finally, in medical therapy, first line is always sorafenib. After sorafenib, if the patient is tolerant, continue sorafenib. If the patient is sorafenib non-responded but tolerant, that means patient has no side effects but the tumor increases, then switch on to regorafenib. If the patient neither tolerates nor respond, then you can choose any of these. So with 3 to 4 simple questions, you can get back to a clear answer sitting in the OPD also.
Well, excellent. I think, Anil, that covers it very well. And with this, I think we come to the end of your presentation, which I'm sure has been thoroughly enjoyed by all of us. And Govind, I'm sure you are there. Can you please do the honors for the closing thing, and there's a lot of information you give us at the end of the talk?
So one more question, last question, if I can ask you. Dr. Chandrakant from AIG Hyderabad has asked, there's a poor consensus on HCC.
Yeah.
So you have not mentioned that. So he wants to know that does it apply to our country? What do I follow?
But the problem is, I'll tell you, to be honest, the problem is we do not have a national database. If the patient goes to an international radiologist or a surgeon, at least in the private sector, he'll not be allowed to come back to a hepatologist ever. International radiologists will keep the patient to them, hepatologists will keep it to them. So where is the national data collection? I think unless you have a national database to have your own recommendation based on just review of the literature does not mean anything. So what I have given is what we practice in day-to-day basis. And this is what is applied in real world of type of practice.
All right.
More stronger, third-party audited database, which is not available. And this is what I'll suggest. I think people at your level can take it up.
I think all of us will appreciate your recommendation for 2 cups of coffee every day. Probably that will save you from your liver cancer. Anyway, thank you, Dr. Arora, for a wonderful talk. I would say masterly talk to giving algorithms for defining HCC. How do you make a diagnosis? How do you approach? And how do you treat HCC? This was a masterly delivered talk. Thank you so much, and many congratulations to you, Dr. Arora. Thank you, Dr. Jain and Dr. Krishna Das for moderating this session. We had almost 210 questions, and Dr. Saraswat, Dr. Krishna Das, and Dr. Jain took many of these questions, and many of them are still not answered. So these questions we are going to send to you. If you can work on these questions, and our viewers get benefit out of it. As all of you know, that all these master classes are archived in ISG library, which you can access by going to ISG website, and you can see all these lectures out there. In addition to that, you have asked many questions, and we have tried to and most of the speakers have already responded to many of our questions. So you can also look to those answers to the question you already asked. With this, we close today's session. But before we close,
Somin, could you? Okay, yeah. Please update them about the upcoming series.
So before we close, there are a couple of things we want to let you know that we are going to continue master classes. We plan 12 master classes. The last talk is next Sunday. That is on May 24th, 12 to 1, our usual time on Sunday. That's a talk on how do you approach to a patient with chronic constipation. And we know that chronic constipation is a very, very important topic for not only for gastroenterologists, but physicians, and in fact, any medical doctor. The constipation is one of the very important disease where they see a lot of patients. So next talk will be on chronic constipation approach on Sunday, 12 to 1. We are extending our master classes to many further weeks, and we have uploaded already the schedule for next 4 master classes, and you can see we will continue master classes, but not twice a week, but once a week. We have been doing on Wednesday and Sunday, but now lockdown is getting open, hospitals are getting ready to start the full scale work. Therefore, we are dropping the Wednesday session, and we continue with only Sunday sessions, 12 to 1 on the usual time. And we have already uploaded a lecture of 4 lecture series on masterclass bedside. With this, we close. We say bye-bye to all of you. Thank you again, Dr. Arora, for a masterly talk. Thank you, Dr. Saraswat. Thank you, Dr. Krishna Das. Thank you, Dr. Jain. Thank you, technical team, for again wonderful relay of today's talk. Thank you, Mr. Ramesh, Mr. Amol, and Yogita for all the support all along. With this, bye-bye, and see you on Sunday, 12 to 1. Okay, bye-bye.
Bye-bye all. Bye-bye.